Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Lilly.
Sarah, John, it's good to see you both. How have things been going since we last met?
Honestly, Dr. Anderson, I'm struggling a bit. The joint pain is really getting to me. My hands are so stiff in the mornings, it takes me a while to even get moving. And the hot flashes, they're happening a lot.
I'm sorry to hear that. These are common side effects from the aromatase inhibitor, but that doesn't make them any easier to deal with. Are they interfering with your daily activities?
Yes, very much so. Between getting the kids to school and working full time, just trying to keep up with everything, I feel like I'm being pulled in a million directions. The pain and exhaustion just make it all so much harder.
She's really been pushing through. I keep telling her to slow down, but Sarah, she won't stop.
Well, someone's got to keep everything running. That's actually why I'm worried about what you mentioned last time about adding another medication. I'm already dealing with so much from what I'm taking now. Do we really need to add something on top of this?
I completely understand why you're asking that question. You've been through so much: chemotherapy, surgery, radiation, and now you're managing side effects from the endocrine therapy. It does feel like a lot.
It is a lot. I just want to get back to normal life.
I know. And I wish I could tell you that what you're doing now is enough. But based on your tumor characteristics, the size of your tumor, the fact that it was grade 3, your 3 positive lymph nodes, and your Ki-67 being 45%, your cancer is considered at high risk for recurrence.
What does that mean exactly, high risk?
It means that even though we've removed all visible cancer and you've completed your treatments, there's still a chance that microscopic cancer cells could be present and could lead to the cancer coming back. Adding a CDK4/6 inhibitor to your current endocrine therapy has been shown in clinical trials to significantly reduce that risk.
But if that's going to make me feel even worse.
That's a valid concern, and we'll talk through what to expect. The most important thing right now is that we're in a critical window. This is our best opportunity to do everything we can to prevent recurrence. I want you to be here for your children, for John, for all the years ahead. Let's discuss your options and make sure you have all the information you need to make the best decision for yourself.
Hi, my name is Shahina Daoud, and I'm a consultant medical oncologist and director of oncology services at the Mediclinic City Hospital in the United Arab Emirates, and an adjunct professor at the Mohammed bin Rashid University of Medicine and Health Sciences. Now, as you have just witnessed, this is the typical young woman trying to cope with the side effects of the treatment she's receiving and balancing it with her responsibility towards her children, her work, and overall her family. Before even discussing the advantages of using a CDK4/6 inhibitor, it is important to first understand the unique needs of a young woman, how therapy overall will impact her life, and how her loved ones can help her on this journey. She is a 45-year-old lady and has gone through chemotherapy, surgery, and radiation therapy that has had a significant impact already. She has now been commenced on endocrine therapy with an aromatase inhibitor and ovarian function suppression. I always find it useful to spend time in discussing all the side effects of endocrine therapy, including how hot flushes, joint pains, and vaginal dryness can become significant issues As you have just heard from the conversation of this young woman, she is scared of the side effects of adding another agent that would negatively impact her quality of life. I find it useful to always discuss risk of recurrence of disease right from the very beginning and introduce it again at various points in a patient's journey so she is fully prepared. It is also important to discuss how tumor size, grade, nodal involvement, and Ki-67 are all factors that can contribute to her risk of recurrence. Her whole therapy plan involving all components of therapy all contribute towards attempting to clear micrometastatic disease that we cannot see and that can ultimately come back as cancer. By adding a CDK4/6 inhibitor to the mix of all her therapy, we would be able to reduce this risk of recurrence, bringing it closer to a patient who does not have any of these phenotypic features. I would strongly avoid telling her that she is at high risk of recurrence, as that can instill a lot of fear. I would rather walk her through the characteristics of her tumor and explain the reason behind her risk and how we can appropriately mitigate that risk. The fundamental question a patient will ask is why now? Why have this therapy now? Why can't I take this medication later on? A simple answer is we can cure you now. If this cancer comes back, we will not be able to cure you. She has her whole life ahead of her, and we want to make sure she will be around to enjoy the graduation of her children and see the birth of her grandchildren. It's important to highlight that she will have the full support of her medical team and her family to get her through and to handle any potential side effects. Let's rejoin the conversation as Dr. Anderson and Sarah discuss the specific treatment options available to reduce her risk of recurrence.
So, let's talk about your treatment options. There are currently two CDK4/6 inhibitors approved for use in the adjuvant setting for high risk hormone receptor positive breast cancer: abemaciclib and ribociclib. Both have shown significant benefits in reducing the risk of recurrence in clinical trials.
What's the difference between them?
That's a great question. Both work by blocking proteins that allow cancer cells to grow and divide, but they have some differences in how they're taken and their side effects. Abemaciclib is taken twice a day, every day, continuously for 2 years. Ribociclib is taken once a day, but on a schedule of 3 weeks on, 1 week off for 3 years.
So with the ribociclib, she'd get a break every month?
Yes, exactly. Some patients appreciate that week off, while others find it easier to take a medication every day without having to remember when to stop and start. For someone with your busy schedule, Sarah, the continuous daily dose might actually be simpler. You can make it part of your routine without tracking an on off schedule.
That makes sense. I can barely keep track of everything as it is. But you mentioned side effects. So I'm already dealing with these joint pains and the hot flashes from the aromatase inhibitor. Are these new drugs going to make that worse?
The CDK4/6 inhibitors have their own side effect profiles, which we'll discuss in detail. But I want you to know that if the joint pain from the aromatase inhibitor becomes too difficult to manage, we have options. With abemaciclib, we can switch you to tamoxifen instead, which may be better tolerated. That's an important consideration.
Wait, so I wouldn't have to stay on the aromatase inhibitor if it's not working for me?
Correct. We want to find a regimen that's both effective and manageable for you. The goal is to reduce your risk of recurrence while maintaining your quality of life. With ribociclib, we'd need to keep you on the aromatase inhibitor, so that's one factor to consider when we're choosing between the two.
Well, what about the effectiveness? Is one better than the other?
Both have demonstrated strong efficacy in reducing recurrence risk in clinical trials. The choice often comes down to individual patient factors: your lifestyle, other medications you might be taking, how you're tolerating your current therapy, and your personal preferences.
I want whichever one works best, but I also need to be able to function. I can't afford to be laid up with side effects when I've got my job and my kids to think about.
Absolutely. And that's exactly what we need to consider together. Let's talk more specifically about what to expect with each medication so you can make an informed decision about which option is right for you.
So, as you've just seen, we're now trying to introduce the integration of a CDK4/6 inhibitor into the therapeutic plan of this young woman. There are two important phase 3 clinical trials that has looked at the use of adjuvant CDK4/6 inhibitor in patients with a high risk of recurrence. The first was the Monarch E trial that took patients with high risk disease. These were classified as patients who had 4 or more positive lymph nodes or 1 to 3 positive lymph nodes in a high risk factor, such as grade 3 disease or a tumor size of more than 5 centimeters or a high Ki67. These patients were randomized to receive either 2 years of adjuvant abemaciclib with endocrine therapy versus just getting endocrine therapy alone. And as you've all seen, at 76 months of follow up, which is approximately 6.3 years of follow up, the addition of abemaciclib improved IDFS by an absolute of 7%. The overall survival was recently shown at ESMO last year, and you can see that the overall survival improved from 85% to 86.6% with a hazard ratio of 0.84. This translated into a 7-year absolute overall survival benefit of 1.8%. The second important clinical trial looked at another adjuvant CDK4/6 inhibitor in the form of ribociclib. This was the Natalie study. Again, this took patients with early stage hormone receptor positive, HER2 negative breast cancer. Here they had high risk patients similar to that enrolled in Monarch E, but it also included a broader cohort of patients, which included high risk node negative patients as well as those patients who were not considered high risk but had node positive disease. They were randomized to get 3 years of adjuvant ribociclib with adjuvant endocrine therapy versus just adjuvant endocrine therapy alone. And you can see that at 5 years of follow up, IDFS was improved by an absolute of 4.9%. There is still no overall survival advantage that is statistically significant, but we have seen a positive trend towards benefit in terms of giving 3 years of ribociclib. Now, the data for both CDK4/6 inhibitors are strong. They both reduce the risk of recurrence of disease. Abemaciclib, with longer follow up, has now shown an overall survival advantage, and ribociclib shows a good trend for overall survival. The critical question is which CDK4/6 inhibitor should you choose and for whom? There are some differences that can help you decide, including first, the dose schedule. Abemaciclib is given twice a day without breaks, while ribociclib is given once a day on a 3-week on, 1 week off schedule. Scheduling can matter for patients, especially patients who find it hard to keep track. In this clinical scenario, we have a busy working mother who has to do multitasking. As such, taking medications should be made as simple as possible. Second, the length of therapy. Abemaciclib is given for 2 years, while ribociclib is given for 3 years. Duration of therapy may be important when considering therapy options. Third, side effects. Abemaciclib is typically associated with diarrhea, and a discussion around risk of blood clots is also important. Ribociclib side effects are typically hematological, and we should not forget there is a small but significant risk of a QTc prolongation. Fourth, the ability to change endocrine therapy may be essential when discussing therapy options for your patients. Abemaciclib can be given with both tamoxifen and an aromatase inhibitor, while ribociclib can only be combined with an aromatase inhibitor since its combination with tamoxifen can increase the risk of QTc prolongation. The ability to be flexible with endocrine therapy backbone may be a deciding factor, especially in younger premenopausal women. Ultimately, what you decide to give will be a shared decision making process between yourself and the patient, assessing what would be most suited for that particular patient. Both agents work and they work very well, but what works best, particularly and practically for that particular patient, will be the key deciding factor. Now, let's rejoin Sarah and Dr. Anderson as they discuss what to expect from treatment, including the side effect management and monitoring.
So if we move forward with this, and I think I want to, what should I expect? I mean, day to day, how is this going to affect my life?
That's exactly what we need to talk about. As I mentioned, both medications have side effects we'll need to monitor. The most common one is diarrhea, which can usually be managed effectively.
Diarrhea. I I had terrible diarrhea with chemo. I was running to the bathroom constantly, and it was so unpredictable, and I really don't wanna go through that again, especially not at work.
I completely understand your concern, but I want to reassure you the diarrhea you might experience with the CDK4/6 inhibitor is very different from chemotherapy related diarrhea. With chemo, the diarrhea is often more severe and harder to control. The diarrhea from these medications is typically milder, tends to occur early in treatment, and usually resolves within the first few weeks. Plus, it responds well to over the counter antidiarrheal medications like loperamide.
So it's temporary.
For most patients, yes. And we'll be monitoring you very closely, especially in the beginning. They'll want to see you every 2 weeks for the first couple of months so we can do blood work and check how you're tolerating the medication.
Every 2 weeks? Sorry, with my schedule, that's going to be challenging.
I know it seems like a lot, but these first few months are critical for monitoring. Once we see that you're stable and tolerating the medication, well, we can space out your visits and potentially arrange for some of your blood work to be done at a lab closer to your home or work.
That would help a lot.
Oh, actually, I have something that I think will help you manage this. This is a monitoring tool we give all our patients starting CDK4/6 inhibitor therapy. It's designed to help you keep track of your medication, any side effects, and your appointment schedule.
This is helpful.
You'll see here there is a place to check off when you take your pills each morning and evening. That way, if you can't remember if you took your dose, you can look back and see. There's also boxes here where you can mark down your blood test appointments, day 0, then day 15, and so on.
And this section here?
That's for tracking bowel movements and any adverse side effects. Each day, you'll note if you had diarrhea, how many times, whether you took any loperamide. This gives us a clear picture of what's happening. So when you come in or call the office, we have concrete information to work with.
So I don't have to try to remember everything.
Exactly. Patients often think they'll remember all these details, but when you're juggling work and family, it's easy to forget. This takes the burden off of you. You'll also see contact numbers for your nurse navigator. If you're experiencing side effects or have questions between visits, do not hesitate to call. You can call anytime.
This actually makes me feel a lot better. It's like I'll have some control over what's happening.
That's exactly the goal. We're a team in this. You won't be managing this alone. And if at any point the side effects become too difficult, we can adjust your dose or make other modifications. We want this to work for your life.
Okay, I think I think I'm ready to do this. I want to do everything that I can to make sure that this cancer doesn't come back.
I'm glad to hear that. We'll get everything set up and start you on treatment. We'll walk through this together, every step of the way.
So, as you've just seen, it's not only about starting a CDK4/6 inhibitor, you need to actually discuss which CDK4/6 inhibitor and how it's potentially going to impact that patient who's going to take it. When discussing the two CDK4/6 inhibitors with your patient, it will be vital to discuss the side effects of each, which could help determine which CDK4/6 inhibitor you ultimately pick. The most common side effects associated with the abemaciclib include diarrhea, which occurs in about 84% of patients but is grade 3 in about 7.8% of cases. Neutropenia occurs in about 46% of patients and is about grade 3 in about 19.6% of patients. And we should absolutely not forget fatigue that can occur in about 41% of patients and is grade 3 in about 2.9% of patients. Ribociclib side effects are mainly hematological, and again, we should not forget that it can be associated with a small but significant risk of a QTc prolongation. Both CDK4/6 inhibitors can be associated with alopecia, although the risk of grade 3 alopecia is very low. Now, whenever I commence a patient on a CDK4/6 inhibitor, I ensure several things. First, education is key when you're talking about side effects for your patient. It will be important for patients to understand that although CDK4/6 inhibitors may be associated with side effects, it is generally very well tolerated. And contrary to circulating myth, it is not chemotherapy, and the side effects are not like chemotherapy. The diarrhea associated with abemaciclib typically happens in the first couple of weeks and then reduces in frequency and intensity and can be managed very well with early intervention with drugs like loperamide. Second, for the first 2 months, patients are monitored every 2 weeks with labs that include a full blood count and electrolytes. If taking ribociclib, they will also have to have an ECG. Post that, they are shifted to a monthly schedule before being shifted to a less frequent schedule of monitoring. This has helped in close monitoring of patients, allowing for early intervention for side effects, ability to withhold therapy early if needed before restarting, and of course, monitoring for adherence, persistence of taking these medications appropriately. During the frequent monitoring period, I have found it helpful to allow for telehealth and a flexible lab arrangement to reduce patient burden. Third, integration of nurse navigators that allow for longitudinal monitoring of patients can be very helpful. I find this specifically very helpful because our oncology nurses can discuss their side effects and monitor more closely, and this allows a patient to feel supported through their journey. Integration of pharmacists has been especially helpful in education and also helping to check for interactions with different drugs that the patient may be taking. Fourth, if dose reduction is needed and necessary, it is important to remember it will not negatively impact prognostic outcomes. So do not fear dose reduction. This has been shown repeatedly across the CDK4/6 inhibitor trials. You can try or you can consider starting off on a lower dose of CDK4/6 inhibitor and escalating it based on tolerance. The TRADE trial is a phase 2 trial that has assessed the tolerability of abemaciclib dose escalation in early stage hormone receptor positive HER2 negative breast cancer. The trial showed that with dose escalation strategy, 70% of patients were able to reach target dose and almost 95% of patients actually avoided drug discontinuation. I find this strategy especially helpful in my older, frailer patients. Integration of a structured monitoring sheets for patients to track their journey with CDK4/6 inhibitors have been actually very helpful. I find it has helped with adherence and adverse event tracking and again allows for early intervention if needed. So, in conclusion, it is important to recognize that each journey is unique and very, very personal. Patients with hormone receptor positive, HER2 negative disease have various risks of recurrence based on various factors, including size of the tumor, grade of the disease, lymph node involvement, and of course, Ki67. It is not only the subtype that matters, but also the risk associated with it. It is important to compute that risk to allow for individualization of therapy plan. Integration of CDK4/6 inhibitors has certainly significantly reduced recurrence of risk in high risk hormone receptor positive, HER2 negative early stage breast cancer. Picking and selecting the type of CDK4/6 inhibitor will be based on multiple factors, including dosing schedule and side effect profile. Proactive management and communication of side effects allows for optimization of adherence and outcomes. I hope you've enjoyed this segment. Thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.